I would say for a non-syndromic patient, because syndromic patients, craniosynostosis, those things, they're going to need maybe a LeFort 2 or 3 higher cuts and bring everything forward with it. These are rare, For most people that have these deficiencies, if they're compensated well and there's a good orthodontic plan, I think that solves a lot of it. I think in terms of planning too, in 3D planning, the orientation, the pitch, putting a appropriate angulation to the jaw makes a big difference. And then the type of LeFort cuts, you have a 2 and 3. I think the 2 and 3 are good for true craniosynostosis, craniofacial deformities. But otherwise, a high LeFort cut where you come higher and you can modify these things.
Mm-hmm.
So it's doesn't have to go to the orbit through the orbital rim exactly, but can go close to it and make a step. You can get a really good aesthetic result without having that imbalance, because at the end of the day, it's all about harmony. And if you're bringing things way far forward, more than the cheekbones or zygoma, it may look inappropriate. But if you can alter the zygomatic bone with it, most of the time you don't have to go to the orbits or above to do that.
So you would be open to performing a LeFort 2, or you think a LeFort 2 could sometimes? Yeah, go ahead.
I think there's definitely candidates that need a LeFort 2, but I would reserve those. It's a riskier operation, and I think that I would reserve those for people with true craniofacial abnormalities. If someone has a Treacher Collins, for example, or these autosomal dominant things where they're really hypoplastic, they're rare. I see a lot of people asking for LeFort 2s and 3s, and I think that for most of these people where I'm reading these requests, a high LeFort, appropriate decompensation, and getting that cheekbone out is going to give a really, really good result and much safer.
Mm-hmm, mm-hmm. Yeah, the people asking you for LeFort 2s and LeFort 3s, where do they come from? From Reddit?
DMs on Instagram.
Yeah.
A lot of times I see it on Reddit a lot too, and I look through these things. And there's definitely candidates that require. I think they're good candidates for 2s and 3s, but I think most of the people are asking need better planning and execution with safer custom planning.
Would you do a 2 or a 3 ever?
I would work with a craniofacial surgeon in the med center to do one, but personally, I reserve that for when I'm at Texas Children's Hospital doing collaborative care versus not.
So you don't think that LeFort 1 is an inherently asymmetric procedure in that it's only looking at underdeveloped faces too low down, where it should look at underdeveloped faces more three-dimensionally? You don't agree with that?
Yeah, no, I know that through experience and with custom planning and designing the cuts appropriately, staying under, not having to go into the orbit itself, you're going to get 90-95% of people and make a very aesthetic face. But if it's cut low and you're not going high on the zygomatic arch, you're not making appropriate movements, and you're not decompensating the teeth or widening the arches appropriately, then it's not going to look appropriate. Then you're right. Then it's narrowing your scope.
Do you ever tack cheek implants into a procedure?
I've done them in the past when I was doing traditional non-custom cases, but now when we can go high in a LeFort, we can make the cheeks as enhanced as they need to be without having to put a foreign implant in there.